Hello friends, myself Dr. Anurag Tiwari, and today I will be showing through this video a case of Genu valgum and how will you plan your osteotomy. So there are multiple osteotomies or multiple options available in an adult patient. If the patient is presenting after skeletal maturity and presenting with Genu valgum or Genu varum, how will you plan the osteotomy, the corrective osteotomy? I will show you here. So let's start this video. So you need a scanogram. Scanogram is a hip, knee and ankle, a full length of the lower limb x-ray. In this you can see the hip, bilateral knee and bilateral ankle. So in this picture, as you can see that there is a severe valgus deformity of bilateral lower limbs. How will you decide? This is based upon your drawing the mechanical axis. The mechanical axis is of the femur is from the center of the hip to the center of the knee, and you will draw another line, that is the distal femoral joint line. So this angle which is being made on the lateral side is the lateral distal femoral angle, that is LDFA. So this is LDFA, the value here in this case is 64 degree. The same way you need to draw the mechanical axis of tibia, that is from the center of the knee or the center of the tibial plateau to the center of the ankle, and another line which is connecting the or through the joint line of the tibia. So now on the medial side, if you will see this angle is now known as medial proximal tibial angle, that is MPTA. So here the value is 92 degrees. So you should know about these two angles, that is LDFA and MPTA, and their normal values, so that you can plan your deformity correction osteotomies. So LDFA, the normal value is from 85 to 90 degree. In this case, in this scenario, we have got LDFA of 64 degree. And similarly, MPTA is here in this case is 92 degree. The normal value is around 85 to 90. So it is clear from the picture. From this you can diagnose that the deformity is mainly lies in the femur, that is the distal femur, because LDFA is very much reduced, whereas MPTA is not much affected. However, it has been affected by 2 to 3 degree. So if we take LDFA, the normal value is approximately we take around 88 degree. So if you want to correct LDFA to around 88 degree, you need 24 degrees of correction in the distal femur, that is must. And in the same way, if you need to correct MPTA to its normal value, you need 5 degree of correction in the tibia. So it is clear from this picture, from this scanogram, that the deformity lies in the femur as well as in tibia radiologically. In the femur it is 24 degree and in the tibia it is 5 degree. So if you go theoretically or if you go by recommendation, ideally you should do 2-level osteotomy, that is distal femoral osteotomy as well as the proximal tibia osteotomy. So in both the bones you need the osteotomy so that you can correct this deformity. So let us see. But however, in this case I will show you through animation only the deformity. We will correct it only in the femur bone. So let's see, just we remove the soft tissue and we will only concentrate on the right side. So just focus here. So I want to correct this deformity, so I will do the osteotomy in the distal femoral. So this is the mechanical axis. Here you can see too much of valgus is there. We will correct the mechanical axis of the lower limb. So I will do the osteotomy in the distal femoral side, and I will rotate this by around this much angle so that the mechanical axis is almost perpendicular or in line with the knee, and it just passes medial or center of the knee joint. In this case it is not passing, but I assume that this is the correct deformity because deformity is too much and we have done only in the femur side. So this angle is now LDFA, correct angle is 93 degree. So you can see from the picture we need almost 29 degree of correction, that is from the past slide or the previous slide you can see that 5 degree and 24 degree. So 24 degree is in the femur we required and 5 degree of correction in the tibia we require. So the total is 29 degree and the lateral distal femoral angle was 64. So 64 plus 29 is 93. So we have corrected the LDFA to 93 degree because we have done both the correction in the femur only, so that the mechanical axis is perpendicular. So this osteotomy is quite unstable osteotomy because here you can see this is unstable osteotomy because this is a large wedge is being removed from the lateral side. The second thing is you will require a bone graft here in order to fill this gap, or if you want to fill this wedge. So this wedge needs to be filled with bone graft. There will be lengthening. In this case, if you are doing this osteotomy, there will be lengthening of the lower limb, and there is a risk of common peroneal nerve injury because of stretching of the nerve because of lengthening. So this is open wedge osteotomy, or you can say as we are doing in the lateral aspect. So it is a lateral open wedge osteotomy. Now similar example we will see another. In this case we will do osteotomy on the medial side and we will remove a wedge from the medial end. So you can see that we have removed a wedge from the medial side and we rotate this bone so that your now new mechanical axis is passing almost center to the knee joint. In this case, the osteotomy is stable osteotomy because there is a large surface area In contact, there is no bone graft requirement in this after osteotomy. There will be, however, shortening of the lower limb, and there is no nerve injury expected. So this is closed wedge osteotomy, or you can say, as we are doing it on the medial side, so this is medial closing wedge osteotomy. Another osteotomy, let us talk about this osteotomy. So this is wedgeless osteotomy, what we are talking. In this case, this is the mechanical axis, and we will do the osteotomy like this. So this osteotomy is actually a curvilinear type of osteotomy, or you can see a circle type of osteotomy, or a dome type of osteotomy has been created. And then you will rotate this bone, and this is the new correction. So this is the new mechanical axis. Very stable, highly stable osteotomy. There is no need of bone graft and large surface area in contact. Definitely it will unite. There is no limb length discrepancy, a major advantage of this type of osteotomy. But however, a major disadvantage is technically difficult to perform. So this is known as the dome osteotomy. So these are the three osteotomies: the opening wedge, closing wedge, and the dome osteotomy. And these are the main advantages and disadvantages of each I have explained to you. Thank you so much.